Okay.
Hi everyone, I'm Dr. Pravallika and I'm a neurosurgical resident from India. And today I'm going to talk about idiopathic intracranial hypertension, also called as pseudotumor cerebri. So today we are going to talk about some introduction, history, epidemiology, signs and symptoms of pseudotumor cerebri, pathophysiology, treatment aspects, and the prognosis of the condition. So, what is pseudotumor cerebri? So, it is described as a condition characterized by a raised ICP without an evidence of hydrocephalus, and there is no mass lesion which can be seen in imaging or no neuroparenchymal abnormalities with normal cerebrospinal CSF analysis. And most commonly, it is associated with papillary edema. Again, pseudotumor cerebri is in turn classified into a primary and secondary one. A primary pseudotumor cerebri is a condition which occurs mostly in young obese women without any clear cause. And in some rare cases, we can identify an etiology, likely it could be a drug induced or secondary to a systemic illness. And it is classified as a secondary pseudotumor cerebri. So the first case of idiopathic intracranial hypertension was described by a German physician named Heinrich Winke in 1893, and he named it as serous meningitis. But the term pseudotumor cerebri was termed by Max Known in 1904, and he raised the concept of increased intracranial pressure in absence of a space-occupying lesion. Later on, Foley coined the term benign intracranial hypertension, but we no longer use the term benign as this condition is associated with almost uh, loss of vision in about 25% of the cases. So now it is replaced with the term idiopathic intracranial hypertension. Coming to the epidemiology, it's when we can clearly see that the incidence is more in females. The female to male ratio is almost 8:1. And if we go to the specific populations, it is more in females of reproductive age between the age group of 20 to 44. And if you go furthermore, the incidence is up to 19 out of every 100,000 women who are obese. And studies also showed that recent and rapid weight gain is highly associated with increased risk of idiopathic intracranial hypertension, irrespective of the baseline weight of the patient. And all the races are affected equally, but when coming to the prognosis part, it is observed that African Americans show a poor prognosis regardless of the treatment compared to other ethnicities. Coming to the signs and symptoms, headache is the most common presenting symptom, and it is seen in approximately 90% of the patients. They usually describe it as a severe pressure-like pain in the bifrontal region, and sometimes it's also associated with neck pain. Some of the patients describe the headache with features mimicking a migraine-like pain. It can be unilateral, associated with nausea, vomiting, photophobia, and phonophobia as well. And some patients say the headache awakens them from sleep, and this resembles a headache caused by a brain tumor. And it also has been aggravated by coughing or sneezing. And the second most common symptom which the patients describe is the transient visual loss, and it is seen in 70% of patients. It can be unilateral or bilateral, but it lasts for only a few seconds, which differentiates the transient visual loss we see in patients with carotid artery or a cardiac valvular diseases. In those patients, the transient visual loss usually lasts for at least 15 minutes. The visual loss in patients of IIH is mostly precipitated by change in posture, like bending over or raising from sitting posture or rolling their eyes. And the frequency can vary, but it can go up to 20 to 30 times a day. This visual loss can be partial or complete. The presence of a transient visual loss usually indicates the presence of severe papillary edema, and it reflects a transient ischemia of the optic disc caused by papillary. And third most common thing we see is loss of vision. The pattern of loss of vision in these patients usually mimics that we see in patients with glaucoma. Usually, it starts with an enlarged dark spot in the temporal visual field, gradually enlarging the physiologic blind spot, and the patient finally can have a tunneled vision or even lose his central vision. Diplopia is also seen in almost 40% of the patients, and it's usually a horizontal diplopia due to an unilateral or bilateral sixth cranial palsy, and it is a non-localizing feature of raised ICP. Rarely, in some patients, we can also see a third and fourth cranial nerve palsy as well. But if it happens to be, we need to rule out or see if there is any other condition that is causing the raised ICP or the cranial nerve palsies. And tinnitus, it is also most commonly associated with it, but patients rarely mention this symptom unless we are asked them directly. And patients usually describe it as a whooshing sound or hearing a heartbeat in their head, and it is more prominent during nighttime and in quiet surroundings. This pulsatile tinnitus is thought to reflect the flow disturbances within the cerebral venous system. Now, coming to the pathogenesis, we all know for sure that there is a raised ICP, but we don't know what is that causing the rise in ICP. One of the postulated theory is that uh, the sinus venous stenosis, which has been found in majority of patients with IIH, is the cause for raised ICP. It is seen that venous sinus stenosis can cause a venous outflow obstruction, thereby causing a venous hypertension and decreasing the CS of absorption, and ultimately increasing the intracranial pressure. This raised intracranial pressure can in turn cause a venous sinus compression. So the controversy finally remains whether the venous sinus stenosis is a consequence of a raised ICP or is it the causative factor for the raised ICP. And some studies also showed that a significant number of patients with IIH do have a jugular valve insufficiency. This when we see an association with obese patients who have an increased intra-abdominal pressure. And in those patients who have a jugular valve insufficiency, this uh, raised intra-abdominal pressure can be directly transmitted to the intracranial venous system. And the second hypothesis is that there is an increased arterial inflow. A study done by Bateman et al., where he saw in some patients with IIH where they have a normal dural venous drainage, but they have an increased arterial inflow. This suggests that there is a collateral venous drainage that occurs in addition to the drainage provided by the superior sagittal sinus and the transverse venous. So, coming to the study they did, they used an MR venography and MR flow quantification in cerebral arteries and veins in 40 patients of IIH. And among the 40, 21 of them had a venous stenosis. But 19 patients showed a normal superior sagittal sinus outflow. However, they found that in these patients, there is a 21% higher arterial inflow compared to the normal group. So this resulted in a mismatch in arterial inflow and venous outflow. And the third one is the relationship between the association between the obesity and IIH. In most patients, the obesity and IIH can be familial. But another theory is that, as I mentioned previously, in obesity, there is an increase in intra-abdominal pressure. This increases the cardiac filling pressures. This increased cardiac filling pressure in turn impede the venous return from the brain, and finally elevating the intracranial venous pressure. As I told previously, in some rare cases, we can find a reason or a cause that is uh, finally leading to a raised ICP. It can be a lesion which is causing an impairment or obstruction of the cerebral venous sinus drainage, or some endocrine and metabolic dysfunctions, or certain systemic illnesses, and exposure to certain drugs or substances or withdrawal of certain drugs are also seen to be associated with pseudotumor cerebri. So this table shows a long list of exogenous substances whose exposure or ingestion or withdrawal has been associated with pseudotumor cerebri. I'll read out some for you. These include drugs like amiodarone, antibiotics like tetracycline, minocycline, doxycycline, fluoroquinolones, cimetidine, lithium, phenytoin, and retinoids. And it also includes some of the hormones like thyroid, beta HCG, oxytocin, medroxyprogesterone, levonorgestrel, etc. And we also see that certain endocrine and metabolic disorders like Addison's disease, hypoparathyroidism, and Turner syndrome were also associated with pseudotumor cerebri. And certain systemic illnesses like anemia, chronic respiratory insufficiency, obstructive sleep apnea, hypothyroidism, Lyme disease, SLE, and so on. The list goes on. So what is the diagnostic criteria for a pseudotumor cerebri syndrome? The first foremost criteria we require is the presence of papilledema. The second one is a normal neurologic examination, except for the sixth cranial nerve abnormality or sixth cranial nerve palsy. And the third is a normal brain parenchyma in a neuroimaging without any evidence of hydrocephalus, mass, or structural lesion, or no abnormal meningeal enhancement on an MRI brain with or without contrast. And we also can go for an MR venogram to look for the venous system. And the fourth criteria is a normal CSF composition. And the fifth one is elevated CSF opening pressure on a lumbar puncture. A CSF opening pressure of more than 250 mm of water in adults and more than 280 mm of water in children is considered to be elevated. So what if the patient comes under, the diagnostic doesn't have a papilledema or a sixth cranial nerve palsy, but satisfies all the rest of the other criteria from B, C, D, and E, then we can categorize them and or diagnose them as a pseudotumor cerebri syndrome if the neuroimaging criteria is satisfied. If they have three of the following, such as the empty cella or presence of an empty cella, or the flattening of the posterior aspect of the globe, or the distension of the perioptic subarachnoid space without tortuous optic nerve, and the transverse venous sinus stenosis, then we can categorize them as the pseudotumor cerebri syndrome. So what is the rationale of using a neuroimaging in these patients? It's mainly to exclude a condition such as a tumor that producing hydrocephalus or a mass effect, and that would put the patient at risk of herniation if we do a lumbar puncture, and also to assure that there is no secondary cause of increased IC. CT scan or a CAT scan is usually adequate to ensure that the patient is not at a risk of having a lumbar puncture. But the drawbacks of a CAT scan is that it is insufficient to exclude certain posterior fossa lesions and also certain isodense lesions. And we also cannot look at some meningeal abnormalities or venous sinus thrombus. Here we can see the CT scan of a patient with IIH. We can see small slit-like ventricles, and there's no evidence of any hydrocephalus in this. Coming to the MRI. In this MRI, we can see the findings like in the image A, we can find an empty cella here, and in image B, we can see the distension of the optic nerve sheath, and C shows the hypoplastic right transverse sinus, and in D, we can see the flattening of the posterior group. Whenever we see an empty cella, it always suggests that there has been a chronically raised intracranial pressure in this patient. Some of the patients also have a carry type 1 malformations or cerebellar ectopia associated with this. And coming to the CSF examination. CSF examination must be done to confirm an elevated opening pressure. And while doing so, we need to make sure that we uh, properly position the patient and see that the patient is not holding his breath or is in pain, because any of this can falsely increase the CSF opening pressure, thereby altering the diagnosis. And we also need to do a CSF analysis to exclude a malignant, infectious, or any inflammatory process that might simulate a pseudotumor cerebri. A diagnosis of PTC should be done should not be made unless the CSF contents are completely normal. Coming to the ophthalmological evaluation, so this plays a vital role in the diagnosis and management of these patients. Papilledema is a diagnostic hallmark of pseudotumor cerebri, and it's present in almost all patients. And in any case, if we see there is a loss of central acuity and with severe papilledema, these patients require immediate and aggressive treatment. If not taken aggressively, these patients are at risk of losing their vision permanently. So, how frequently do we need to do this ophthalmological evaluation? During the initial period of diagnosis at the onset, we need to evaluate them once every 1 to 2 weeks until a pattern of progression or stability is established. Once we get a stability, then we can repeat the ophthalmological evaluation once in every 4 to 12 months. So, how do we can evaluate it based on by doing a clinical visual assessment and doing an OCT. So an OCT gives us an objective quantification of the edema. We can see here that the retinal nerve fiber layer thickness is significantly higher in this case where there is severe papilledema compared to a normal one. And we also can do a perimetry evaluation to look for progressive loss of peripheral field of vision. Coming to the treatment aspect, the approach to the treatment mainly depends on the presence and severity of the symptoms. We look at the severity of the headaches and the degree of visual loss at the presentation and the rate of progression of the visual loss. And also it depends on whether we can identify an underlying etiology. If so, treat them accordingly. The primary goal of our treatment is preservation of the vision and alleviation of the symptoms. If a patient is mostly asymptomatic or with very mild papilledema, we can closely observe them, doing frequent follow-ups and doing a serial ophthalmological evaluations after excluding any underlying etiology. If during any of this evaluation we find a secondary cause, we need to treat it. The first main modality of the treatment is weight reduction. A successful weight reduction results in resolution of papilledema and also return of ICP to normal. Studies show that 6 to 10% reduction in body weight results in complete or at least a more rapid resolution of the condition. And when weight loss efforts fail, we can even consider a bariatric surgery as a long-term management plan. As we all know, it takes time to lose for the patient to lose the weight. But in the meanwhile, to prevent gradual deterioration of the vision, we can start them on certain medications. So among the medical management, topiramate is a drug that has shown promising results. It helps to prevent and reduce headaches, and it also has mild carbonic anhydrase activity, which reduces the CSF production and thereby reduces the ICP. And it also helps in weight loss. But one of the potential side effects of using topiramate is it can induce an angle closure glaucoma. The second line drugs we can use to lower the ICP are carbonic anhydrase inhibitors. These act by reducing the CSF production. And the most common agent we use is acetazolamide or Diamox. Dosage is 1 gram per day in adults. It can be given in divided doses as either 250 mg 4 times a day or 500 mg twice a day, up to a maximum of 4 grams per day. But the usage of acetazolamide is limited by its major side effects. Patients do complain about paresthesias of their extremities, lethargy, and altered taste sensation. And we also should be cautious in prescribing this medication to people who are on antihypertensives, because these drug interactions, patients can develop severe hypokalemia as well. So methazolamide is an alternative to acetazolamide, which is better tolerated. And coming to the role of corticosteroids. Corticosteroids can help to lower the ICP acutely, and this can be used as an urgent treatment plan where there is an impending or progressive visual loss while awaiting a definitive surgical procedure. But the drawbacks of using a corticosteroid is that the withdrawal can lead to a rebound increase in ICP, and the long-term side effects such as weight gain and fluid retention is something which are not desirable in patients with IIH. Then coming to doing a repeated lumbar punches. It is seen that doing a high volume lumbar puncture and removing about more than 20 ml of CSF is likely to help the patients in reducing the ICP. But doing repeated lumbar punctures are traumatic for the patient and are technically difficult. But this can be beneficial in selected individuals, such as a pregnant woman who develops in idiopathic intracranial hypertension. So during pregnancy, these drugs were mostly contraindicated, and studies have also shown that acetazolamide use in animals has shown some teratogenic effect as well. And even doing definitive surgical procedures like a ventriculoperitoneal shunt or a lumboperitoneal shunt would be difficult in a pregnant patient. So for them, for the time being, we can do repeated lumbar punches to protect the vision and to alleviate the symptoms. Coming to the surgical management, when is a surgery indicated? When we find there is a new worsening visual field defect or severe reduction in visual acuity or a headache which is unresponsive to the medication. The surgical options we have are the optic nerve sheath fenestration surgery, lumboperitoneal shunt or a ventriculoperitoneal shunt, dural venous sinus stenting, and a bariatric surgery for weight reduction. Coming to the prognosis part, most patients in whom we identify the condition early and have undergone an appropriate treatment show an excellent visual prognosis. But we have to keep in mind that once the signs and symptoms have resolved, there is always a risk of recurrence in these patients, particularly if they gain weight over a short period of time at any time in their life. And yeah, thank you. And the reference for my presentation today is from Human and Neurological Surgery, 7th edition. And thank you.
Thank you.